And this also speaks to the age-old argument. I'm sure you've had people say, oh, seed oils, they're the devil. And people say, oh, it's all about the carbohydrates. And it's almost like we've got two camps of people in the low-carb community. Some people are afraid of sugar. Some people are afraid of seed oils. Well, in actual fact, they're both toxic. And it's just a dose that informs us about the poison. It's like if you have more seed oils than you do carbohydrates, then the seed oils will be worse. If you have more carbs than seed oils, and vice versa. But on average, when we look at the literature, it appears that for a diet that's about 50 to 70% carbohydrate, that would have about the same impact on your health as a seed oil, a diet that had about 6% of energy coming from seed oils. So if you understand that, then consider that the average Australian gets about 13% of their energy from seed oils. It actually looks like seed oils may actually be even more problematic in the diet than carbohydrates for most people. So there's an interaction between leptin and insulin. So in effect, if you deal with the insulin, you're going to be dealing with the leptin. So I used to test the leptin levels on every patient, and that was academically informative, but it didn't change management, because we just saw this tight relationship between what's happening with the insulin and what's happening with the leptin. We just know that we fix the insulin and we don't need to worry about the leptin. And the reference intervals that the laboratories will give you for leptin are just so nonsense. It makes, if you're interpreting it based on the reference intervals, you're going to be out of luck. In terms of things like cortisol, for some people that is hugely important. So I've got condition called Cushing syndrome or Cushing's disease. If you take too much steroid because you've got a chronic inflammatory illness, or you might have a problem with your adrenal gland where that secretes too much cortisol, then that absolutely will cause obesity as well as a bunch of other side effects. And occasionally I do cortisol level testing in most of my patients who come in because I don't want to miss this. But the reality is, for most people, it's actually not that important. But there are other hormones that we have to always test. So take the thyroid gland, for example. So what we call subclinical hypothyroidism, which is really a euphemism for saying an underactive thyroid that standard blood testing doesn't detect. That's really what it means. That is very common, and that absolutely contributes to weight gain. And it also will contribute to elevated cholesterol levels and elevated triglyceride levels. So we'll see a lot of people come in and they'll say, oh, my doctor put me on a statin because I've got high cholesterol levels. And you'll look at them. And the way I think about cholesterol is not as a disease. If we treat it like a disease, where you've got high cholesterol, here's the drug you need. No, it's as a symptom. If you have high cholesterol, it's because there's something else going on with your body. Now, and I'm not talking about, just mid-range, cholesterol that the reference intervals call high, because we know that, the very basis of, the targets for cholesterol have just lowered over the years, and it's basically, it seems to have basically been done to increase the amount of people who take lipid-lowering therapies. The number of people over the last 20, 30 years who are eligible for cholesterol medication has actually increased 600%. That's just because we keep moving the goalposts down. So I'm not talking about just slightly high cholesterol. I'm talking about proper high cholesterol. But if you've got proper high cholesterol, then we shouldn't look at it like a symptom. Well, we should look at it like a symptom, and not a disease. So it might be that you've got an underactive thyroid gland. It might be that you're actually deficient in B12. How many doctors realize that low B12 causes the body to increase production of cholesterol, for example? Often we see high triglyceride levels in people who have what we call hemochromatosis. And it doesn't mean that you have to have both genes for hemochromatosis. You could just have what we call a carrier state where you've got one affected gene. And that will frequently lead to elevated liver enzymes, for example, elevated triglycerides. So we do need to have visibility of these things across the board. So for most people, the key is insulin. But there is a certain subset of people who do have other hormonal disturbances. And that would probably be in the vicinity of 10 to 20%. So, most people, they're not issues, but they're certainly worth checking for.